This is the third part of a series of addressing the diabetes mellitus. We spoke about the introduction, physiology, classification and diagnosis, evaluating diabetic patients, and the last time we finished with the topic of type 1 diabetes. Today we are going to be discussing in more details type 2 diabetes. First, we need to understand the nature of type 2 diabetes and the nature of the progression disease. Remember the metabolic syndrome in which the patient is overweight and there is something called insulin resistance. Overweight, it alters the fat content of the cell and it results in impairment of the insulin action of the target cells, namely the adipocytes and the muscle cells. As a result of the insulin resistance, the pancreas will start to compensate with the deficiency of the insulin action by increasing the insulin production. So it moves to the second stage, which is hyperinsulinemia. Initially, the pancreas will be able to produce enough amounts of increased insulin, which will be able to control the blood glucose level. This is the third stage in which there is compensated insulin resistance and the ability to maintain normal glucose levels. But gradually, because of the increased workload on the pancreatic beta cell, the pancreatic beta cell will start to decompensate and passes through the stage of 4, in which there is the beginning of the beta cell decompensation. And finally, after failure of the beta cell to cope with the blood glucose level, there will be the stage of impaired glucose tolerance, which is stage 5. And impaired glucose tolerance, as it continues, there will be complete failure of the beta cell to produce enough amounts of insulin to control the blood sugar, in which there is total failure of the beta cell, stage 6. And finally, this will result in the appearance of the clinical features of the type 2 diabetes. This diagram, it represents the different contributing factors for hyperglycemia in type 2 diabetes. First, there is a defect, central defects, in which there is the defects in the satiety center, which makes the diabetic patients continuously overeating even when there is enough caloric demands. And there is also increase in the gluconeogenesis by the liver and impaired insulin secretion and increased glucagon production by the pancreas, and there is a defective secretion of certain gut hormones, which is called glucagon-like peptide, and we shall address this in more details in few slides. And there is an increase in the production of glucose by the kidneys in the process of gluconeogenesis, and increased release of the fatty acids, which will provide the substrates for the glucose by the liver through the process of gluconeogenesis. At the same time, there is deficiency in the glucose uptake by the muscles, and all these contributing factors will result in eventual hyperglycemia observed in type 2 diabetes. Now, to understand the progressive nature or the natural history of the disease, this is a very nice curve, and have a look here on more than one parameter. First, insulin resistance and insulin secretion. At the initial stage in which there is hyperinsulinemia, the insulin secretion is able, or the pancreatic beta cells are able to cope with the increased glucose level by increased insulin secretion. And here, look at the blue curve in which there is insulin secretion is increased. This is the stage of hyperinsulinemia. But gradually, as there will be an increased overload on the pancreatic beta cells, the secretion of insulin, as we can see here, it will start to decline, and there is a very high level for insulin resistance. And finally, when there is total failure of the pancreatic beta cell, the insulin secretion, it will drop, and the insulin resistance will continue, and the fasting blood glucose and the postprandial blood glucose, both they are going to be elevated in this stage in which the diabetes will be diagnosed according to the clinical criteria. This is another diagram which represents the nature or the progressive nature of type 2 diabetes, in which there is a progressive decline in the pancreatic beta cell mass. Here, this is the years after the diagnosis of diabetes, and this axis, it represents the pancreatic beta cell mass. And look, as the time goes on, there is a decrease, gradual decrease in the pancreatic beta cell mass until we reach a stage in which there is total failure. And the importance of this diagram, it explains the necessity of initiating insulin therapy in certain cases of type 2 diabetes after a certain period This is the same diagram with another format in which it represents the initial stage of diabetes where we have an impaired glucose tolerance. At the stage of impaired glucose tolerance, there is increase in the pancreatic secretion of insulin, and at this stage, it's partially reversible. In other words, during this stage, if the patient follows proper diet and exercise, actually the disease could be reverted and the pancreatic beta cell will start to function normally. We call this stage, this is the stage of primary prevention. Primary prevention in which you recognize your patient in the impaired glucose tolerance phase and you can revert him back to normal. This is primary prevention because you are preventing the development of diabetes. But once diabetes starts to reveal itself according to the clinical criteria, you start treatment of diabetes whether with oral or with insulin, and your aim is secondary prevention. Secondary prevention meaning you are aiming to prevent the complications. The third category of the patients in which they are already having complications, and we are aiming at tertiary prevention in which we are aiming to decrease the disability and to prevent death by strict control of the blood sugar. So we have here three different expressions: primary prevention, secondary prevention, and tertiary prevention. And now we understand the difference between the expressions. Now, what is the clinical presentation of type 2 diabetes? First, we recall a basic factor on physiology, which is the renal threshold. The renal threshold for absorption of glucose is about 180 milligrams per deciliter. So the classic symptoms of diabetes regarding the polyuria and polydipsia, they start to occur if the blood glucose exceeds the renal threshold, which means there is a category of patients in which the blood glucose is elevated, but it didn't reach yet the renal threshold. Accordingly, they will be asymptomatic. So this asymptomatic phase occurs because the blood glucose level is truly elevated and it fulfills the criteria of diabetes. However, it didn't reach the renal threshold. This is the asymptomatic stage. On the other hand, sometimes the clinical presentation of the disease might be a drastic metabolic complication, quite similar to diabetic ketoacidosis in type 1 diabetes, which is called hyperosmolar non-ketotic syndrome. We will speak about this in the next presentation. Now, according to our understanding of the progressive nature of diabetes, gradually there will be a decline in the pancreatic beta cell mass, which means you can start with a patient of diabetes and he will be well controlled by diet and exercise. But as time goes on, there will be more decline of the pancreatic beta cell mass, and the patients will need to be controlled by more than one oral medication or insulin. And as the disease progresses, there will be failure of the oral medications, which will necessitate initiation of insulin therapy. We call this is the natural history or the natural progression of the disease, which means the patient at the early stage starts with good control with diet and exercise, but gradually over time, because of the decline of the pancreatic beta cell mass, there will be a necessity to initiate more than one drug or even to initiate insulin therapy. And that's why there are certain selected cases of type 2 diabetes. According to certain criteria, it is quite wise to initiate insulin therapy from the start in certain selected cases if the blood glucose level is too high and if the A1C is high, because in such a case, the initiation of insulin at a very early stage of the disease will actually prolong the longevity of the pancreatic beta cell mass. On the other hand, there are minority of patients in which the initial presentation will be actually the presentation with the complications. In other words, the patient for the first time he is seeking medical advice and he is already having retinopathy, neuropathy, or even nephropathy. Now, what about the treatment of type 2 diabetes? The treatment of type 2 diabetes is a tripod. Most important thing is diet and lifestyle management. This is very important. And then we will say a few words about what is called bariatric surgery, and then we will discuss in more details the pharmacologic therapy. It's quite apparent that the most crucial item in the treatment of type 2 diabetes is diet and lifestyle. Diet and lifestyle including proper exercise and controlling of the carbohydrate and the sugar intake. What about bariatric surgery? What is bariatric surgery? Bariatric surgery is the type of surgery which is performed in order to reduce weight, which means there are certain subsets of diabetic patients who are overweight who might benefit from this bariatric surgery, and it was found that the blood sugar will be controlled long before the actual weight loss will occur. And this is related to the change of certain gut hormones that we will discuss later, which will include the glucagon-like peptides. And what are the indications of considering bariatric surgery in a diabetic patient if the body mass index exceeds 40? So bariatric surgery is a part of the management of diabetes in cases of diabetic patient who is overweight with a body mass index more than 40. And this diagram, it represents the three major categories of the bariatric surgery. We have gastric banding, sleeve gastrectomy, and row-on-1. Actually, the most popular of these bariatric surgery types is this one here, which is the sleeve gastrectomy. This is the most popular type of bariatric surgery performed for diabetes. Now, we will discuss the pharmacologic therapy for type 2 diabetes. Now, general principle regarding the pharmacologic therapy. We need to initiate oral medications, and usually the oral medications are given to the patient with just one class of medication. We call this monotherapy. Monotherapy meaning you are selecting one class of medications and you give it to the patient, and you start to increase the dose until you reach the maximum dose in order to control the blood glucose level. An important fact regarding the efficacy of oral medications. There are certain classes of oral hypoglycemic drugs which will take just few days to exert their maximum effects, and this includes certain types of insulin secretagogues. And there are other classes of oral medications which will take several weeks in order to reach their peak effect to control the blood glucose level, including metformin and thiazolidinediones. The importance of knowing this fact is that when the patient is starting on medication like metformin or thiazolidinediones, the treating physician should expect that there will be a lag of several weeks before the blood glucose is well controlled. Now, another important fact regarding the initiation of oral therapy, sometimes we are confronted with certain patients in whom the blood glucose level is too high, exceeding 240, and the A1C is more than 9. In such category, the high blood glucose level will be most unlikely controlled by selecting one drug. So in these cases, it is wise from the start to choose or to abandon monotherapy and to choose two drugs belonging to different classes. Or even sometimes for these patients in whom the initial blood glucose level is high of more than 240 and the A1C is more than 9, it is wise to use a combination of oral medication and insulin therapy in order to achieve good control in the shortest period of time. Now, what are the various medications available for treatment of type 2? Now, the medications for treatment of diabetes are divided into oral and parenteral. The oral medications include biguanides, alpha-glucosidase inhibitors, dipeptidyl peptidase 4 inhibitors, and insulin secretagogues of the sulfonylurea class, and insulin secretagogues of the non-sulfonylurea class, and we have thiazolidinediones, and finally we have sodium glucose cotransporter inhibitors. These are the available classes of oral medications for treatment of diabetes. About the parenteral, definitely the most famous one is insulin, and we have glucagon-like peptide agonist, and we have amylin agonist, and we will be speaking about them in full details in few slides. Now, there are certain basic facts that we need to understand in order to understand the rationale of use of various medications for treatment of diabetes. The first rationale is the role of the incretin. What is incretin? There is a quite known physiologic fact. If we administer the same amount of glucose, oral and IV, it was found that the amount of insulin produced by the pancreas with the orally administered glucose exceeds that when it is released in response to the parenteral, which means that there is some hormones or there are some peptides produced by the gut in response to the orally administered glucose. And these peptides include many classes, and the most important of them is what we call glucagon-like peptide 1. And it was found that the glucagon-like peptide 1, it has certain beneficial effects regarding the control of the blood glucose. For example, it decreases the glucagon secretion and it slows the gastric emptying, and it also has a central effect which will promote satiety. Which means that these gut hormones, the most important of which is glucagon-like peptide 1, they might have a potential in the treatment of diabetes. This diagram, it represents the glucagon-like peptide effects. The glucagon-like peptide, remember, these are the gut hormones released in response to the orally administered carbohydrates. So the actions of the glucagon-like peptide 1, it increases insulin secretion, suppresses glucagon secretion, it decreases glucose production by the liver. In other words, it suppresses gluconeogenesis and it suppresses appetite. All these effects make it actually quite tempting to use such a modality in the treatment of diabetes. So the question is, how these glucagon-like peptide 1 be used in order to control the blood sugar in type 2 diabetes? Here we have a look again on this table. You have here the basic defects in type 2 diabetes and the corresponding action of glucagon-like peptides. In type 2 diabetes, we have impaired production of insulin, and it was found that glucagon-like peptide, it increases insulin secretion. And in type 2 diabetes, there is reduced pancreatic beta cell mass, and it was found that glucagon-like peptide, it enhances beta cell proliferation. There is glucagon hypersecretion in type 2 diabetes. The glucagon-like peptide, it suppresses the glucagon secretion. And there is obesity, in which the corresponding action for the glucagon-like peptide is it decreases the gastric emptying. So all these effects makes the possibility, high possibility for the therapeutic potential of use of glucagon-like peptide 1 in type 2 diabetes. How could this be achieved? Now, there are two ways in order to utilize the glucagon-like peptides in the treatment of type 2 diabetes. Number one, the enzyme which is responsible for degrading glucagon-like peptide, it is called dipeptidyl peptidase. So if we suppress the activity of this enzyme, this will enhance the effect of the glucagon-like peptide. So the first approach is using what we call dipeptidyl peptidase inhibitor. The other approach is there is another class of medications which will act on the same receptor of glucagon-like peptides, and this is the glucagon-like peptide receptor agonist. And this is called the incretin-based treatment. The incretin-based treatment is actually dependent on two mechanisms. Number one, suppressing the dipeptidyl peptidase or acting on the receptor. So we have two major classes of medications who possess the incretin-based action, which are the dipeptidyl peptidase inhibitors and the glucagon-like peptide agonists. This is another table which shows the combined beneficial effects of the incretin-based treatment for both the glucagon-like peptide receptor agonist and for the dipeptidyl peptidase inhibitor. On the pancreas, they promote insulin secretion, and on the liver, they suppress the effect of insulin and they suppress gluconeogenesis, they delay gastric emptying, and they also act on the satiety center. Now, another class, or another extremely interesting class of oral medications for treatment of diabetes, which is the sodium glucose cotransporter inhibitor. These medications act primarily on the kidney, and they simply inhibit the absorption of glucose, which means we are inducing actually an iatrogenic glycosuria, which means that there will be increase in the glucose secretion in the urine. Subsequently, the blood glucose will drop. Subsequently, the insulin action will be much better. And it's very important to realize that the effect of the sodium glucose cotransporter is insulin independent. In other words, they don't have any effect on the pancreas, on the liver. They simply act by inhibition of absorption of glucose, increasing the secretion, and once the secretion of glucose increases in the urine, subsequently the blood glucose will get low and the diabetes will be better controlled. This diagram, it represents the overall action of the sodium glucose cotransporter inhibitor. We have here hyperglycemia, and you start administering sodium glucose cotransporter, which will increase the secretion of glucose by the kidney, and subsequently the blood glucose will get lower and there will be decreased production of the glucose by the liver through the process of gluconeogenesis, and when the blood glucose is lowered, and you will get an improved insulin secretion and a better insulin action on the target tissues, namely the fat tissues and the muscle tissue. The most important side effects of the glucose co-transporter inhibitor, since we are increasing the concentration of glucose secreted in the urine, this will represent a good nourishment and good nutritive media for bacteria, so it is associated with higher incidence of genitourinary infection, and a severe form of this infection, it is called Fournier gangrene. Fournier gangrene is a peculiar type of gangrene which occurs at the external genitalia, and this is a recorded side effect for the sodium glucose co-transporter inhibitor.